Welcome, my name's Ian Campbell from Palliative Care Australia, in Canberra on the lands of the Ngunnawal and Ngambri peoples. Welcome to Thursdays at 3, our regular series of conversations with people living and working at the end of life. Today, we meet the winner of the 2023 award for Outstanding Achievement by an Individual in Palliative Care, Kate Munro!
Yay!
Kate, how are you going?
I'm good. Look, I've even got the award in the background just to prove that it's true and it was real. I'm very proud of that. Very proud of that. Thank you. And thanks for having me. It's really lovely. I feel like, an old war horse, still upright and breathing and kind of working in and around this area. So I feel very lucky that that's the case, although I shall be exiting left fairly soon. But the award was a lovely, lovely moment. Very overwhelming, like completely overwhelming. But again, I think a lovely opportunity to reflect on 50 years of working, not always in palliative care, but never far from it. So yeah, it was a lovely, lovely moment. And I was very thrilled.
I'm looking forward to our chat today, Kate. You're so much more than just that one award. As you say, you're coming up for retirement in July, 50 years of non-stop nursing across all sorts of health disciplines. I think we're in for a good chat today. Your current gig is nurse manager at Hunter New England Local Health District, centred around Newcastle in New South Wales. What does a day look like for you?
Oh, gosh. Well, I guess in recent times, I've moved more into reflective practice, which is a lovely way to kind of round off my career at working in clinical supervision and Schwartz rounds and things like that. But a day can look like, someone ringing up. We created these beautiful, which I must credit the Gold Coast girls for, the CEC's Last Days of Life Toolkit has this beautiful logo. And we created what we called handover bags. So we have these beautiful brown paper bags with a little grief note inside it, because it broke my heart watching relatives walking out of hospitals with pink plastic bags with their loved ones who remain. Like, it's awful, broke my heart. So we got some of these for the International Year of the Nurse. We got them printed and we're thankfully still printing them, which is lovely. So like this morning, I had a lovely chat to one of the nurses in the rural sector going, Kate, how do I get those brown bags? Oh, you mean the handover bag? So just having a lovely chat to her about, life, how things are. They're struggling in a minute. They don't have a GP, and just things are tough in our rural settings. We often think, and look, it's all relative. You could work in the giant John Hunter Hospital and it's still tough.
Yep.
Or you could be in a little tiny rural setting and it's, tough. So I think just, you never know what the day is going to bring, and you never know what the phone will bring or an email
Yep.
or whatever. And I think that's one of the loveliest things about the job that I've had sort of more or less for the last 10 years is kind of just being support for people. And just if I don't know, I know who to ask, that kind of. So I fingers in lots of different pies. I'm a great networker. I like networking. So as I say, if I don't know, I'll make it up. No, not really. So that was just this morning, and then more meetings, and it's just one of those things. You never know what the day's going to, and I like that. I like the not being in a routine. You just never know what the day's going to throw at you.
And look, we can hear your phone pinging away.
Oh,
you're a wanted,
sorry.
You're a wanted person. No, not at all. Not at all.
I turned it off. It's all good. Sorry.
Catch up and get your wisdom. But we've got 50 years of your career to reflect on, Kate. It all started 1976, other side of the world, at the Royal Belfast Hospital for Sick Children.
Yeah.
What led you to nursing? Do you remember those early days?
I've been telling this story a bit recently. So I have two older brothers. One we just celebrated. He died 25 years ago, and we got all the family together in Australia yesterday, which was lovely. So, and then my other brother, they both came to Australia. But when I was born, we had Dr. Simpson. We called him the old doctor because his two sons became doctors. So he was known as the old doctor. And so he delivered me, and he rang my father and said, well, Wallace, you've either got a nurse or a housekeeper. And so that was his way of saying to my dad, well, you got a girl. And so because my mother had been a nurse, but you had to stop nursing when you got married in her era,
Of
So
course.
I guess it was kind of predestined that I would nurse. I don't know. But I started at the Royal Belfast Hospital for Sick Children when I was 17. And I rang my mother every day going, Mum, can I come home? I don't like it. I don't like it. I did that for weeks. Going, I don't like it, Mum. I don't like it. Thankfully, she kept me there. She kept saying, no, it's all right. Just give another day, give another day. And I guess I kind of find a groove. I was always in trouble because I grew up in a questioning family where we questioned everything. I didn't understand things. And I had terrible times. I was awful. But there was something in the caring. And even as a 17, 18, 19-year-old, it was caring for the children, but it was also for their parents and family, whatever made up their family. And I think that's where I kind of got a sense that this strange thing called being a nurse is actually really holistic. It's not just about your patient in a bed or a cot, as in the children's hospital, but it's actually who constitutes their family, which I think is a natural transition to working in palliative care, because it is the holistic whole kit and caboodle, dogs, cats, horses, whatever makes up your family. And I think, being a caregiver or a nurse gives you access to being able to be supportive. And, at the end of the day, reflecting on ringing my mother every day, can I come home? Here I am all these years later, but I think it's that gift of listening. And she listened to me every day and very quietly, confidently, she said, it's all right. You'll be right, dear. You can come home on Friday. So I think that gift of listening, I think, is one of the greatest gifts that palliative care people have. Because you hear all sorts of things and you need to hear all sorts of things. So I think that was a gift that I learned really early on about palliative care and why I love it.
As you say, listening and palliative care goes hand in hand, because I guess it and you know this better than me, certainly, but I get the sense that good palliative care starts with a conversation, with, what do you want? What's important to you?
Yeah, absolutely. And, it's interesting that, whether it's the palliative care conference or the palliative care nurses conference or, nothing has changed in all of the years I've been going about. So how do we make people feel more comfortable about having conversations about death and dying? And I always chuckle to myself going, why bother? Like, it's I don't think it's necessary for all of us. It would be lovely. But I think we put a lot of pressure on ourselves as palliative care clinicians, wanting everybody to be in this place of truly accepting of death and dying. I don't think we can, quite frankly. It's a very emotional, difficult, stressful time. I think if we can engage in conversations about it, sure. But I have a sense that it's not something everybody needs to be engaged in. And it's one of those things that, we spent years working in palliative care trying to do, things in newspapers and radio and all sorts of communication styles and standards. But really, at the end of the day, if it's not your space and you're not knowing or needing to know about that, you're going to just go, oh, no. Because we live in a death-denying society. Who wants to talk about death and dying, for God's sake? I do, because I'm Irish and I love it. But I'm a little bit weird. But not everybody does want to talk about it. And I think we as palliative care clinicians need to kind of get that. But we do need to be very clear when somebody is ready and needs us. We have very clear communication around what it is and what it isn't. I think we can talk a lot about generalization stuff, but I think if people aren't in that space, then they don't want to talk about it. Like,
look, I think that's really wise.
It's a novel way of being, as opposed to ramming it down people's throats. Which I used to do.
You will talk about death and dying, and you will like it. Yes.
Yeah. Well, it's interesting. One of my favorite books is the Bottom Drawer book, which is this beautiful journalist, ABC journalist up here in New South Wales, whose mum died and she wasn't prepared. She didn't know anything. And so she created this, and now it's a whole movement thing with her, but it's one of my favorite books. But when the time is right, it's perfect, because it can guide you in those conversations about what kind of songs do you want, or what hymns do you want, or, do you want to be shot out of a cannon? Do you want to be made a diamond? You can have these sort of conversations in the right space and in the right place.
So breaking it down to be a bit more practical, and getting people to think about those little things rather than the big thing.
Yes.
Mhm.
Yeah. When we used to do a lot of education around advanced care planning and stuff, you know, I would say to people, why would you go straight to resuscitation and peg feeding and, you know,
Yeah.
I don't want to think about that. But I can go gently entering into, so what sort of service do you want? Do you want to be buried? Do you
Yes.
want to be, you know, that's a safer way to open the
Yes.
door a little bit about, well, what would you like? You know, working in the acute settings, we're not very good at recognizing when this might be someone's last admission. But if we looked at their track record for the last 12 months, we'd have seen they've probably been presenting 2 or 3 times to an ED department. They may have had, you know, 2 or 3 admissions, but we are so focused on getting them back out the front door. Well, it could be the morgue as well. We don't really care because we need the bed. You know, it's kind of like we miss so many beautiful opportunities to plant little seeds.
Yeah.
So I think things like, you know, the bottom drawer book is really, really good because it gives you a safe way of talking about stuff.
When you talk about those opportunities to plant little seeds, is that also about referring people to palliative care much sooner, much earlier?
Yes. And I think, you know, that has been since palliative care first, you know, was invented, if you like, although guess what? We've been dying forever. And it's not new, but, you know, I guess from a medical point of view, formalizing it. You know, I had time out and I came back and I was quite confused by this specialist palliative care because I thought, isn't palliative care just palliative care? But I got to understand. But, you know, but I think it's difficult, that referral process. In an ideal world, you know, we would have lovely specialists who would refer really early, or people would feel confident to be able to say, I'd like a palliative care referral, even though, you know, it's not about dying yet. Because the reality is they're fantastic at symptom control and pain management and all of that sort of stuff. You know, if you got in early and then buggered off for a while, it would be great. But I also understand not, you know, sometimes it's physicians hesitant about handing over care or consulting, but often it's about people as well, because when they might not necessarily understand what palliative care is, but they know it's, oh, I'm going to die. So I understand from a human point of view, there's a hesitation maybe. Why are you getting palliative care in here? Like, I'm not dying, am I?
Have you given up hope?
Yeah, that's right. Are you giving up on me? You know, like, so it's that delicacy of listening and that delicacy of good communication, of understanding how empathetically and compassionately we could introduce the concept of a consult. But we sometimes we're a bit territorial. You know, it's our turf. You know, but it's also a human response to being told, well, maybe, you know, we could refer. So unfortunately, we do get too many late referrals. But it's
you talk about that. You talk about that human response to a palliative care referral, which I think connects with that whole death-denying society conversation we were having before. But just picking up on that element of hope we touched on there, does hope play a role in palliative care?
Oh, it's almost, you know, the first thing, really. I mean, it's not really, but it should be at the core of everything that we talk about, because, you know, I can't tell you the number of conversations where someone has said, oh, you know, I can't go yet because my grandchild's going to be born, or, you know, it's about us having confidence to be able to say to someone, what has meaning to you? What is meaningful for you? What, you know, what can we do for you that will make it okay? So hope is not, you know, hope for a cure or climbing Mount Everest, or, you know, we once had a patient who made the throwaway line of, well, I guess I'm never going to climb Everest now. And it was kind of like, well, probably not. But we were able to manage, because one of our OT, our allied health people, had a husband who had climbed Everest. So he came in, brought in his climbing gear, sat with him, you know, talked about what it felt like, showed him, you know. So he got to kind of climb Everest, you know. And I think that's one of the loveliest things that we can do in palliative care. But if he had not thrown away that line, you know, that probably wouldn't have happened.
Is that where the wins are, Kate?
You know,
is that where the success is at in palliative care? Your patients die in the end, but is that where the wins are? Yeah.
Well, I love what Joe Doran says, you know, you die, but you get a certificate. You know, I don't think I think we should wear T-shirts. You know, like yes, you can, but you get a certificate.
Yeah.
I loved that line. I thought that was brilliant. You know, but I think there are lots of times and palliative care nurses all over Australia do this on a daily basis. You know, whether it's you bring a horse in, you know, whether I remember we had this man who came into the hospice who had no one in his life, like no one. He wasn't terribly old. And when I went to see him to chat to him about something, he said, look, I don't want to talk this dying stuff. It's not important, because he said, I've had a crap life. I saw you have a pharmacy. I saw the sign on the website. She'll give me good drugs. I went, yeah, probably. So I said, so well, what can we do? He said, I just want ice cream. And I said, ice cream? He said, yeah, but you know those little tubs with wooden spoons? He said, I want one of those. But he said, I want them for breakfast, morning tea, lunch, afternoon tea, and dinner. And if I want one at night, I want one at night. And I went, okay. And I said, so, okay, we actually have those. That's okay. We'll put that in your chart. You know, we'll chart that for your medications. Ice cream. And I said, so can you tell me a little bit about what that was? And he said, well, I was in and out of foster homes all my life. And all I ever wanted was a little tub of ice cream, but I never could. And he said, so I know I'm dying. I'm not worried about that. And he said, so I can just eat as many ice creams as I want. So, you know, he died very peacefully. It was good medication and good symptom control. But you know what? He had his lovely ice creams, and he had his last ice cream when he said to the nurse, that's it, I'm done. And he did. He died not long after.
Yeah.
So,
Yeah.
you know, having specialist palliative care and the knowledge and symptom management blows me out of the water that you know, our medical staff and our nurses and our OT staff and allied health are so amazing at symptoms. Thank goodness. But it's also that humanness that, you know, I want to eat ice cream. That was the most important thing for this man. He didn't care about pain. He didn't care about dying. But ice cream was, you know, and so that gives you joy as a clinician to be able to go, yeah, we can do that. That's easy.
Kate, we're having a laugh and really speaking of the joy that can come with your work. But there is an emotional weight that comes with this work, a load that that sticks to you. How do you deal with that emotional weight that builds up over time? How have you dealt with it over your 50 years?
Not always well. I think that the difficulty is that we as clinicians don't always see it when we're not traveling so well. But I think that's one of the lovely things about palliative care is that you work with good people. Mostly, you know, you do. And they're actually the ones who know when you're not traveling so well. And they're the ones who can trip you up and nudge you and say, are you okay? And I've been fortunate that I've had some people along the way who have tripped me up every now and again. Now, if I go quiet, people should worry, because my father always said, we'll never lose you, darling. We'll always hear you. I think he said it with love. I'm not sure. But if I'm quiet, there's something wrong with me, you know, or I'm just actually focusing, concentrating, which I do occasionally. But it's good to have people around you, because sometimes I think when you're dealing with this sadness, and it is sad, it can accumulate. I used to call it like Post-it notes stick to you, you know, and if you don't take those Post-it notes off at the end of your shift, it builds and accumulates. And so you do find yourself getting short, or, you know, not wanting to go to work, or just being weary, you know, or all sorts of coping mechanisms that possibly aren't terribly healthy. But if you've got good people around you who you trust, they're often the ones who pick up when you're not traveling so well. So, you know, I don't have any great strategies around it other than listening. And I have a really good supervisor who keeps me on the straight and narrow, and I thoroughly recommend it for everyone. It's challenging, and I sometimes don't want to go, but I know I walk out of the session going, oh, that feels better. But yes, I think having someone who you can talk to and share stuff with is really important. And you can do all the other stuff. You know, you can eat ice cream and you can walk on the beach. You can do all those other lovely things. But I think having a buddy who you trust, who you can share with. And, you know, there will be patients and families that you just fall in love with. They're just fabulous and you love them. And then there are families that you don't. You know?
It's a human business,
Yeah, you kind of go, oh. I have to say, I often find being Irish woman, I often find those the challenging ones I love the most. Well, they teach you. There's a lovely palliative care doctor, Dr. John Kavanagh, who's no longer with us. I hope he's palliating people wherever he has gone. He always said that, you know, you can go to seminars and conferences and read books. And he said, do all of that. But he said, never forget your patients are your greatest teachers. And it's something I've adopted and adapted all my life. And they are the people who teach me about compassion. They're the people who teach me about, ooh, why am I itchy, scratchy with this person? What's going on? But I think our patients really are our greatest teachers, and the families.
Kate, you lead me to my next question around how working with death and dying influences how you lead your life outside of work. I can see that that's been the case for you, that your work has really influenced how you lead your life.
Yeah. Well, I think many, many, many years ago, there was an educator in the community, Margot, who used to talk about having a little parrot sitting on your shoulder who would whisper in your ear, you're going to die one day. You're going to die one day. So I've always adopted that kind of like a little parrot. And I used to sort of sometimes say, you can bugger off now. And, I don't need to hear that today. But I think it's one of the gifts that we don't actually acknowledge or talk about working in this space, that you have a real appreciation for being alive. Like, I'm upright and breathing today. I'm 67. I'm about to retire. I've worked for 50 years. But you know what? I'm upright and breathing. I can't ask for more, really. I've had a great career in that sense. But just working in the world of death and dying, which is emotional. Like, it's highly, highly, highly emotive. But I think it gives us access to recognizing how short life is. I used to talk about the gospel according to palliative care. Do it now. Don't wait. As a great nudge for me when I didn't want to do something, I'd go, gospel according to palliative care, do it now.
Yes.
It was a nudge to do it. But I think it gives you a real preciousness about life and how short it is. And even when you're having a crappy day, and sometimes I have to say, over the years, I've gone to a lot of meetings that, where you take minutes and lose hours. But you sit there and I look at some people and I think, oh my God, you're going to die. And it just gives you freedom a little bit to kind of, be in the same space as them, because we're all going to die. Like, we are all going to die.
We've got that in common. Yeah.
So I just think it gives you a bit of a quirky outlook. Not taking it too seriously, really.
Kate, here we are at the end of your 50-year nursing career, and I guess one of the new things that the palliative care sector is dealing with, that I think our whole community is dealing with, is voluntary assisted dying. Only new to New South Wales, came into force in November of 2023. How's that playing out for you in your head and your practice of palliative care, but also within your palliative care circles? How's it going?
Well, 28th of November last year, we ticked over. I have to say, it again is one of those things that is a beautiful opportunity for palliative care clinicians, regardless of what your belief is, to actually sit down in a safe space and talk about this. I used to be a fervent evangelical, almost opposition. There's a beautiful, she's an Australian ethicist, philosopher, Margaret Somerville, who'd worked in Canada. I think she came back to Australia. But many, many years ago, there was a palliative care conference in Perth. So you can imagine there's a huge, big, 1,000 people sitting, palliative care, doctors, nurses, everybody. And she's the opening kind of plenary session. And she stands up there and she talks about her opposition to the principle of euthanasia, as we didn't call it VAD, we called it euthanasia. And she said, why would you want to take the mystery of life and death away? And she really not chastised palliative care people, but she kind of gave us a different way of thinking about, and I guess my Celtic Irishness kind of went, ooh, I like that. Why would we want to take about the mystery, birth, death, we talk about from the cradle to the grave. Why would we want to interfere with that? But I've mellowed a lot over the years, and also, talked to a lot of people, did a lot of reading, particularly in the lead up to New South Wales bringing in the law. But I think I have a sense of gratitude for the physicians and nurses and managers who put their hand up to make a safe choice for people in New South Wales. So they're protected, they're safe, they have good quality staff looking after them, if that's the choice that they want to make. And I think it's a difficult one to sit in the world of palliative care, but I think it sits within palliative care at one level, because people may choose that. And the thing that I think I've probably mellowed a little bit is, where with the grace of God go I might want VAD one day. So if I'm evangelically opposed to it, where does that leave me? So morally, I don't like it. I don't like that it's law. I like to think that people, and we talk in palliative care about people just need good access to palliative care. Well, the real world is that's not the reality for an awful lot of people. Either by resources or geography or choice or whatever. And so I respect people who conscientiously object, but I think we have to be, put our big girl and boy pants on and kind of go, guess what? This is now the real world. We're now living with it. So how can we best incorporate it into our care? And I think that is that thing about sitting down with a cup of tea, bit of cake, talking about it a lot. I think that's one way that we have of perhaps giving people permission to own how they feel. It's okay to feel that way. But if we're working, say, in a unit that has a room that's set aside for this, that, we actually explore our judgments around it, and we have the faith and ability to be able to say, this is not for me. I just can't actually do that.
Yeah.
And that be okay. I think we have to be generous enough to be, that's okay. Because there will be people who are not happy, but are okay with being involved in it. So I think there's a lovely happy medium in there, is my thinking.
Cake and tea are such a tool for so many things, such a vehicle for so many changes and good conversations. What about your retirement plans, Kate? More cake and tea? You have none?
So I'm going to go home and sit in my bottom for quite a while. I could say
I thought so, yes. I can see you doing nothing. Yeah.
Yeah, I'm just going to go. My lovely wife bought me 2 kittens as a retirement present. So I'm going to go home and play with them. Yes, which is lovely. I'm going to go and sit for quite a while, I think. But somebody asked me, is there something I wanted to learn in the next 12 months? And I grew up in the north of Ireland where the sea is very cold. So I want to learn how to swim properly. So
awesome.
Somewhere in the next 12 months, I shall be learning how to swim.
Great.
Really, I have a great belief in things organically turning up. So I'll be no doubt not sitting on my arse for very long. I can't help but be involved and get stuck into things, and I will always be a passionate advocate for end of life care. That doesn't change. Whether you're a worker or whether you aren't, it's just part of who you are, for me anyway. So God help people, I'm still going to be talking about it.
Kate, a real privilege to spend this time with you. Thank you so much for not just this time, but your service over 50 years or more. Thank you so much, and we wish you well for retirement. I have no doubt we'll cross paths again. Thank you for your time.
Thank you very much, Ian. That's lovely. Thank you.
Take care. Kate Munro there, nurse manager with Hunter New England Local Health District, wrapping up 50 years in July. Thank you so much for tuning in to Thursdays at 3, whether that's via PCA socials or Spotify, and engaging in matters of life and death. You'll find advice, tools and support at the Palliative Care Australia website, where you can also make a donation to support our work. See you next Thursday. Ta-da.